Good afternoon, everyone, and welcome to the California Black Health Network's Health Equity Forum about a new technology breakthrough in cancer screening and early detection. I am Rhonda Smith, the Executive Director of the California Black Health Network, and we thank you for taking time out of your busy day during this holiday season, I'm sure, to join us this afternoon. I also would like to give a big thank you to GRAIL for their continued support, their commitment to science and innovation, and their work to help improve health outcomes and especially cancer outcomes in under-resourced and underserved communities. So why are we here today talking about multi-cancer early detection technology? Well, cancer is about to become the leading cause of death worldwide amongst men and women. And about 224,000 new cancer cases and about 74,000 cancer deaths are expected to occur amongst Blacks here in the US in 2022. Unfortunately, African Americans and Blacks have the highest death rate and the shortest survival rate of any race or ethnic group in the United States for most cancers. For example, Black women are 41% more likely to die from breast cancer compared to white women, despite the fact that they have a lower incidence rate of the disease or get it less often compared to white women. We know that early detection is the key to survival, and we hear that all the time, and regular screenings do play a role in that. However, the current cancer screening protocols that we have in place are only for about 4 to 5 single cancer types like colon cancer, cervical, prostate cancer, and breast cancer. Unfortunately, though, most cancers are still found too late. About 70 to 80% of cancer deaths are related to cancers that have no screening protocol at all, like pancreatic cancer, ovarian cancer, and multiple myeloma. But now, thanks to companies like GRAIL, screening individuals for multiple types of cancers is becoming more available. That's why we're here today to talk about the importance of multi-cancer early detection protocols and technology. So we can learn about this new technology for screening a variety of cancer types called the Galleri test, which can detect over 50 different types of cancers. So we'll hear about how this new technology can help close the gap in cancer disparities, especially in the Black community. But before we get into the meat of our discussion today, I'd like to just go over a few housekeeping rules. So we will hear from our guest speaker, Dr. Jason Carey, and we will engage in a conversation about the important work that GRAIL is doing relative to multi-cancer early detection technology and what can be done to eliminate the barriers to access this technology for all communities. And so at the conclusion of my conversation with Dr. Carey, we'll open the floor for Q&A from the audience, but you can always put your questions in the Q&A box. The chat box will be active, so if you see someone that you know and want to give them a shout out, feel free to do that, or you can add your commentary as we go along, but please try to put your questions in the Q&A box. Everyone will remain muted and off camera during the webinar. And I'm looking forward to a really robust discussion and learning more about the Galleri test and the multi-cancer early detection technology. But before we introduce Dr. Carey, I'd like to just say a few things about CBHN and tell you a little bit about who we are for those of you who may not be familiar with the organization. So CBHN is actually about to turn 40, so next year we'll be 40 years old. Our vision from the very beginning has been to improve the health and well-being of Black Californians. We do that through our mission every day, and we work to really make sure that no matter who you love, where you live, how much money you make, how well educated you are, everyone has access to high quality, equitable healthcare and primary and behavioral healthcare. And so we work every day through our outreach activities, education, like the session today, policy and advocacy work, and some of the programmatic work to try to close the gap in health disparities and ultimately improve life expectancy of Black Californians. So I want to not take up too much time because we have a lot to hear from Dr. Carey, and I want to welcome him back to the Health Equity Forum. He was here once before in 2021 with representatives from the Henrietta Lacks family. But Dr. Carey today is going to talk about the promise of multi-cancer early detection technology, why and how it can be beneficial for our community, and how you can help really contribute to the success of this new technology in the Galleri test. So I'll tell you a little bit about Dr. Carey himself. He is, hold on one second. Dr. Carey is the Senior Medical Science Liaison at GRAIL, with over a decade of experience in oncology and molecular diagnostics. As a medical science liaison at GRAIL, he is responsible for educating physicians and the community on the benefits of multi-cancer early detection technology. Dr. Carey has focused his career on improving the ability of cancer patients to survive and thrive against cancer by first investigating novel treatment therapies to improve patient outcomes. So now to GRAIL with finding cancers at the earliest possible time when cancer patients are more likely to survive. So with a focus on health equity and clinical implementation, Dr. Carey is charged with bringing this technology, the Galleri test, to patients and populations that need it the most and otherwise wouldn't have access to this innovative technology. So Dr. Carey, welcome back. I'll turn it over to you to share information about GRAIL and the work that you're doing around MCED.
First, I want to thank you so much for that introduction, Rhonda. And I want to thank CVHN for having me here today and welcoming me back. I always enjoy my time here. And to your point, I don't even know if I need to go through my presentation because you've done such an excellent job in explaining why we need new technologies such as multi-cancer early detection, why this test is needed. But more importantly, I'm here to really discuss how is this relevant to your audience, to everybody listening. But more importantly, for everyone who's listening, I want you to think about how is this relevant to everyone around you, your family members, your close friends, and so on. And so where we are right now is a revolution. How do we bring technology into the space of healthcare to really make sure we get better outcomes for, so far classes of individuals and demographics that may have been left behind through whatever reason or whatever social determinants of health may be at the crux of that. So I want to start off with the promise of multi-cancer early detection. Now, before we get there, because I am an employee of GRAIL, I have to give a disclosure that I work for the company, and so that I do have equity in the company. But as Rhonda stated, right now, we have hundreds of types of cancers. Most of us, I myself was kind of surprised to realize just how limited are we in detecting cancers early. Right now, the cancers that we screen for, breast, prostate, colon, lung, and cervical cancers, just 5 cancers, they encompass only 25% of cancer-related deaths each year. So what that tells us is 75% of the cancers that people are dying from each year, we're not even bothering to screen from. And I don't want to sound trivial in saying bothering from. We don't have the technology or the utility to really detect these cancers at earlier stages. And so this is the crux of why this technology was developed, researched, and really is here to you today, is because we need to do more, right? To avoid the impending future that Rhonda talked about, to where we're facing a future where cancer is the #1 killer of everyone, but more importantly, to your audience, Black people. And we have some data that'll really show you where we are with the status of that. And so on that note, I want to bring you to, this is actually data from ACS, and it's in a publication that GRAIL really published last year. And so what we have is, we know that prostate and breast are some of the major killers of all individuals, right? They have very high incidence rates, and those deaths can be seen across all cancer types. But what are we doing to combat those death rates, right? And from this data, you can see, and this emphasizes, I gave you on the previous slide, really a snapshot into what we're not doing for those cancers we aren't screening for. Well, here's the impact of that data, right? For the number of cancers that we're screening for, they encompass less than half in males and and a little bit more than half in females. But more importantly, let's look at the deaths. This is just another way of looking at it. How many people are dying in cancers where we have no screening options? And we can see for males, that is a much higher rate at 187,000, and at females, 154,000. So again, this is why we need this technology. And there's something that we in the cancer oncology community don't often talk about, in that cancer or death from cancer is more often associated with late stage diagnosis. We're failing to diagnose more cancers at earlier stages. And even though stage 4 cancer diagnoses only encompass 18% of cancer-related deaths, they equate to 18% of all cancers diagnosed each year, they equate to 45% of cancer-related deaths. And why is that important? Well, stage 4 cancer diagnosis means it's metastasized, it's spread, it's just gone too far, too fast, and we're finding it at a time point where there's not a lot of hope or options. But if we were to diagnose more of these stage 4 cancers at earlier stages, when they're localized, when they haven't spread, when they're in their infancy, the survival rate, the 5-year survival rate, is 89%. And so this is what we want. We want to limit the number of cancers that we're just detecting too late and really detect them early on, so that patients who have treatment get cured and go on about their life. And so this is really that paper that I referenced that was published earlier this year by Grail. And because we know that we were really doing something paradigm shifting, right? Unleashing a test on the world that had the ability to detect over 50 different types of cancer. First, we needed to understand, what does this community need? And so we needed to understand stage 4 diagnoses. And here again, you can see what is the expected cancer death rate within 5 years for both stage 4 diagnosis as well as all stages across various demographics. And I'll actually get to the highlight. Here's my impact statement. More Black males are dying from cancer than any other demographic, right? Black females are the 3rd highest mortality rate across all demographics. Now, this isn't a scenario of, are we diagnosing more late stage in these demographics? You can see across the board, it's pretty similar how many we're diagnosing in stage 4, but those ratios are pretty high. If we would take and I want to linger on this slide, because it's one thing to look at it, but when we really dive into it, we're dealing with a lot of numbers, a lot of ratios. 80% of people of any race diagnosed with stage 4 cancer are dead within 5 years, right? That's why we don't want stage 4 diagnosis. Getting back to Black males are dying from stage 4 cancer diagnosis at a 30% higher rate than white males. Black females are dying from stage 4 cancer, well, not from the stage 4 cancer diagnosis, but after a stage 4 cancer diagnosis at a 16% higher rate than white females. And just if we would compare those two that demographic by sexes, Black males diagnosed with stage 4 cancer are dying at a 57% higher rate than Black females. And we know a lot of this information anecdotally, and I'm really not trying to harp on it, but it's not until we look at the data and understand why we need to do better or do more or change the system or address these inefficiencies is where we can really start to make a difference. And so just one last component about understanding, why are Black males dying from cancer at a high rate or stage 4 cancer diagnosis? When we look at the data, here's the irony of it. The top cancers that Black males are dying from, the top 5: lung, colon, prostate, head and neck, and pancreatic cancer. Now, listen to that. 5 out of those top 5 cancers, and that's not all, but out of those top 5 cancers, 3 of those we have current screening technologies for: lung, colon, prostate. Head and neck and pancreatic are the 2 which we currently have no screening options. But what it tells us that even with the technologies that we have, it's not enough, or it's not enough to make a difference in what we're seeing in the data. So we need more. we need to adhere to the screenings that we should be adhering to, but also employ new methods, new awareness, education around these topics. It's more than just one test. It's really about a movement. So moving on now, let's come to why I'm here, or the technology behind this. And so this technology really had a serendipitous development, where this technology really developed at the opposite of what we're talking about, death, actually at the beginning of life or during pregnancy in women, where, you know, initially prenatal testing or non-invasive prenatal testing for women, where they're wanting to understand, you know, are their babies healthy? Do they have any genetic abnormalities? And in that test, we saw the first evidence that we could detect cancer in the blood. And that is where these tests were providing some feedback. There was something off in the blood. And it was later found out to be those abnormalities were not any issues with the baby, but what was actually being diagnosed were the early evidence or signs of cancers. And so from there, Illumina, which is the company that owns Grail, actually published this data to show we can start to look for cancer in the blood. And so we went down this journey really to understand, how do you develop not just a test that can detect cancer in the blood, but make it effective, efficient, and ready to be utilized at population scale? That's not an easy task. Just because you can say you can do something doesn't mean you can do it well. And so in order to get to that point, we focused on 4 primary or core principles. The first being that we wanted to detect as many cancers as possible. That should be obvious, but with any technology, there's limitations, or, you know, the hungrier your appetite, the less ineffective you may be. And so we really had to understand, how do we do this in an efficient level? Then we also wanted to complement, not replace, current single cancer screenings. I just emphasized that many of the cancers that Black males are dying from are the ones we have screening measures. If we have any Black males in our lives that are not doing the recommended screening, this is not the test for them. I want them to do the screening that's recommended, that exists, that's out there in the market first, before they even consider this. This is another tool, not the only tool, not the primary tool, and it's not meant to replace what we should already be doing. Secondary, we had to optimize overall cancer detection, right? And that in and of itself requires a lot of fine tuning of the instrument to make sure that the information we're getting back is tailored to our audience. And lastly, we wanted to minimize harm. There's not enough said about the mental anxiety that can be associated with getting this information or this report or this test that says you may have cancer, and then waiting a month, 3 months, 6 months before you can actually know whether or not this information was wrong or whether it's right, or even start treatment. And so by minimizing harms, we believe we've done that by making sure we have not only an accurate test, but a test that does not often report false positives with a 0.5% false positive, but also tells you where to look so that you can get to that diagnosis as quickly as possible. So this is the test. It should be ordered by your primary care physician after a consultation. Then once he authorizes the test, it's sent to our lab, and there we do methylation sequencing, or we look at the DNA for signs and evidence of that cancer. And then the results are sent back to the primary provider. There are only 2 options. This isn't really a complicated test. It will either say no cancer signal detected, and the incidence of cancer in the population is 1%. So this isn't going to happen to everybody who takes the test. But for the 1% that are going to get this cancer signal detected, this test is designed to say, let's jump on this. Let's diagnose this and let's treat this, so this can be more of an issue of your past than your future. And so from one of our clinical trials, and we have many clinical trials, as I'll show you in the data, what we know, as has been stated multiple times, this test detected, not guessed, not may detect, it detected over 50 different types of cancers in this clinical study. on the top portion of the screen, these are all the cancers we're not screening for. We have no technology to screen for. So these are the patients that are benefiting, or these are the cancers that are benefiting from this technology. But even so, in a high screening, a high adherence to screening population, we still detected breast cancers, cervical cancers, colon, rectum, lung, and prostate. So overall, this test had a very high accurate rate of predicting once there is a positive result, it's likely a cancer diagnosis. Again, I remarked on this low false positive rate, but again, even within these 50 different types of cancer, there's a smaller subset, right? This test actually detects the 12 most deadly cancer that cover 2/3 of US cancer deaths each year. We're talking about things like pancreatic, ovarian, lung, colon, head and neck, esophageal, at a much higher rate. And so what we found is that this technology is actually fine-tuned to detect the most aggressive cancers. Then lastly, that ability to say, where should we be looking in this body has approximately an 89% accuracy. And so these are the features that we thought we succeeded in developing the test. Now, this test is commercially available. And if you are interested in the test, I implore you to talk to your primary care provider. But we are still understanding what are the possibilities with this tech. Where can this technology take us? And because of that, we've been lucky enough to have over 335,000 people participate in our clinical trials across the world. We have clinical trials in the US, clinical trials in the UK that are really designed to understand how does this test work for a population of women who are actively undergoing mammogram, or individuals who are at high risk for lung cancer. How does it look when we implement this test in a clinical setting? How quickly can we get a diagnosis or return of results? We're looking at population scale across various demographics by partnering with the UK, but we also want to know in a real world setting, who are the individuals willing to take the test and how are they receiving the results, and how accurately or how long is it taking to diagnose those results? And I'll actually get remark on one of the opportunities for anyone currently to participate in our clinical trials, one of our studies that's currently enrolling. But I remarked specifically on this Pathfinder study, which was designed to assess the clinical implementation. We published these results for the first time this year. It was the end of the study and it was completed, and we showed the evidence of what this test means. And the test doubled the number of cancers detected versus the screening methods that we currently had: mammograms, colonoscopies, cervical cancer screening, PSA, etc. But more importantly, 50% of the new cancers diagnosed were in stage 1 or stage 2. Going back to that slide where I showed you we're not screening for 75% of cancer-related deaths, that's because, and without that screening, we're often detecting those cancers in later stages when people show up with signs and symptoms. So the fact that this test demonstrated the ability to detect these new cancers was a win for this technology. There were also no adverse events, and the test was highly accurate in terms of directing that diagnostic workup. And so where do we go from here? Well, we're just at the beginning of the road. I'm thankful for this opportunity to actually speak to you about this test, but by no means are we anywhere close to the finish line. In many ways, I don't even know if we've reached the starting line as yet. So we have to start off with broaden awareness. I want you need to know about this. I want you to tell everybody that you know about this, anybody that you think. And here's the thing, for the cancer survivorship population, for people who've been had cancer within their circle, they self-educate and they want to know more. They want to know how can they avoid it. But sometimes where we drop the ball is making sure everybody else understands all that hard work that has gone into educating ourselves. Then there's the scientific rigor. I've already presented to you our role in terms of developing rigorous clinical trials that will provide the evidence for not just you, but for the scientists, the doctors, the regulators across the world to really understand what will this technology mean for the population. And then lastly, meaningful partnership. This is a meaningful partnership. I don't care if just one person heard this conversation today and they decided that either they needed to screen, they needed to tell their mother, their father, their cousin that ended up getting screening, or they talked to their local representative about why isn't this test covered by insurance yet. And so lastly, that brings me to coverage and access. And so this is the challenge. In order to get to the point of where this will have access for all, we need insurance coverage. We need our legislators to work towards getting this covered. And it's a long process, and I won't get into all of the details, but I will give you one nugget, and that is that there is a Multi-Cancer Early Detection Screening Coverage Act, a bill. It's written. It needs to get voted on by Congress individuals, by the Senate, and signed by the president. And once we have that, then we will have access for more. So if you want to find more about this, you can read into it. What is it going to take to get this bill passed, or whether or not it's worthy of being passed? I implore you to look into this information. Lastly, I want to come back to this study, Pathfinder 2. I presented the research results from Pathfinder 1. Well, here's the crux of it. COVID shot us in the knee with that one. And what that means is we conducted that study during COVID. And one of the things that we were really excited about, we wanted to see how quickly could we go from the return of results to test to diagnosing a cancer. Because believe it or not, it doesn't happen that quickly currently in the field. But because we conducted that study during COVID, there were limitations in getting appointments and screenings and imaging and MRIs and all these other things that really hampered our ability to understand. And believe it or not, we still had very good results, but we think it could be better. But that issue with COVID actually turns to the benefit for more people, because what it turns into now, we're repeating the entire study. We're looking to get 20,000 participants who are over 50 years of age, and they will get this test free of charge if they participate in the study. There are multiple sites all across California. We're partnering with Sutter Health. So if you're interested, I suggest you reach out to Sutter Health, or maybe even CVHN can actually provide additional information and resources for anyone that's interested in that study. But again, this will be a study that will allow individuals to be screened. And for this study, we are seeking up to a 30% minority inclusion in the study. So we want to have representation. We want to be able to say that this works not just for one demographic over another, or that it isn't applicable across demographics. We want everyone to be involved in this study. And again, it's an opportunity to get novel new technology really before many people maybe have access to it. And so I'll stop on the note and actually hand it back over to Rhonda.
Thank you, Jason. That was a lot of good information. And I was noticing folks in the chat saying, wow, I didn't know about this, that there weren't screenings for other types of cancers or all types of cancer. So this is really important technology. And so I guess I want to start my conversation with you by really trying to get a better understanding of the accuracy of the Galleri test compared to the standard screening that we're all familiar with. And I think one of the things that, correct me if I'm wrong, that is a benefit with the Galleri test is that there are fewer false positives with the test. Yeah. So maybe you can talk about it from that vantage point as well.
Yeah. And so let me preface this by saying, when you develop these screening tests, there's an either or option. You can't have your cake and eat it too. So if you want a test that's really, really sensitive, which is the way the previous screening, the generation of screening tests have been developed, then you kind of have to give up what is called specificity, meaning how often does it give a false positive rate. To your point, we developed this test on the opposite side. We wanted to make sure that we were not doing harm. And so we focused primarily on the lowest achievable false positive rate. And we achieved that at 0.5%. That's statistics. However, when you compare this to something we know about, like a mammogram unfortunately has about 11% false positive rate, meaning 11% of the time it's returning a result of a false positive. So we have a 22% difference in the false positive rate between our test and a mammogram. And so for a woman who's undergoing a mammogram, she gets an abnormal result. Again, we're talking about anxiety, we're talking about fear, we're talking about waiting to get the next test to understand what that means. And, we even understand sometimes some people are so afraid that they prolong getting that next test. And so what we have with this test, it's actually something that your physician should want to follow up on the next step as quickly as possible, because the positive result has significant meaning. And so, sorry, let me pause and actually come back. Could we talk about the sensitivity of the test across all 50 different cancers is 50.5%. And so I do not try to gloss over that. What it means is it detected half of the cancers in our clinical trial. But here's the thing about that. It's not because there's something wrong with the test. When you're doing a test like this, it is limited by the ability for whatever it's looking at to be in the blood. So this is a blood draw. What you go to the phlebotomist, the doctor, they draw your blood, but that cancer has to be shedding a signal in the blood. In the world of cancer, not all cancers are equal. Believe it or not, there are some good cancers, and I don't want to diminish a cancer diagnosis for anyone, but there are certain cancers that when we diagnose them, they're not expected to lead to high mortality rates. Sometimes they're called indolent. We see this in early stage breast or even DCIS and prostate. There's often indolent prostate, to where the physician says your prostate is so early, we're going to take a watch and wait approach. We don't really want to treat it aggressively yet. And the reason for that is the chemotherapy or the therapies that are associated with the treatment may sometimes be more harmful than the cancer itself. And so what we have with this technology, it's actually skewed to detect the most aggressive types of cancer. My brain is jumping the gun on me. I know we've talked about this, but even if you go to breast cancer, this test detects the less aggressive form of breast cancer, hormone receptor positive, at a much lower sensitivity, less than 30%. So again, this test should not replace your mammograms. However, when we talk about more aggressive types of breast cancer, like triple negative, HER2 positive, et cetera, this test has a almost threefold higher sensitivity for those cancers. And we know that the Black population are a population that's highly diagnosed with triple negative, these very aggressive forms of breast cancer. And again, this shouldn't replace your mammogram, but if that fails you, this is another option to maybe this can add additional surveillance. And that's what we're hoping. We're hoping for more shots on goal, right? It's like when you're driving in your car, you don't just rely on a seatbelt or an airbag or brakes. There are multiple safety features to make sure that you're as safe as possible while driving your vehicle. We should have the same thing in our efforts to sustain longevity and avoiding cancer.
Thank you for that. And so I guess the next question, when you talk about the signal, so to me, what I hear you saying is, mammograms, it's kind of a one size fits all approach to screening. But to me, it sounds like with the blood draw, it really is bordering on being more like personalized or precision medicine,
Yeah.
right? Right, because you're looking at what is happening with that individual. So can you elaborate a little bit more on that?
Yeah, and that's a very good question. My career before I came to Grail actually was in the field of precision oncology, where there was a time where we gave everybody chemotherapy, hoping that they would all respond, and we obviously know that only some respond, but that was it. There was chemotherapy, and that was it. Now, through the invention of next generation sequencing and really understanding our DNA, now we know that, hey, this patient will respond to this treatment, this patient will respond to that treatment based off of their DNA. They have different treatments that they should be getting. Well, now we're using a new tool that can have the same effect in the screening population, to where the precision medicine part is the part saying, well, this test is detecting this cancer. Let's take an individual with prostate cancer. Again, this test shouldn't replace PSA screening, but if they have a high PSA and they have a Galleri positive, that means something totally different than if they just have a high PSA. And so, yes, this is a version of personalized medicine, but I expect as we move towards a future of, self-driving cars and flying cars and all that stuff, that it will become even more personalized. Even some of the most recent data that I'm looking at, we're trying to even improve upon the technologies that we have with artificial intelligence. And that's one of the key factors. We can talk about what the technology is, but I don't want to scare anybody in terms of, really get deep into the science. But what we have here are two revolutions in screening. One being the thing that we're looking at has never been looked at before in screening, and that is methylation. The other part is now we're taking it out of the hands of humans, out of the hands of just, mathematical, out of the hands of humans or pathologists, as we like to think about it. We're actually employing artificial intelligence. We're using measures that can correct for some of the biases that may occur. And so those are the two revolutions at play, both the biological technology as well as the computer technology that's really being employed in this test.
Right. And so you bring up something that I think is really important when you talk about artificial intelligence and machine learning and its application in medicine, which I think really emphasizes the importance of more diversity in the Pathfinder 2 study that you mentioned. So can you talk a bit about that? Because we know in the past with some of the medical algorithms, they've incorporated more biases into that particular aspect of medicine. So can you touch upon that a little bit?
Yeah, we spoke about this recently to where, we said some of the fear in participating in these clinical trials or even, getting it early was that it's experimental, it's new, all these other things. But here's the thing, everything in oncology, even the mammogram was experimental at some point. All of the drugs, there was a new drug approved by the FDA just yesterday. And that was experimental before yesterday. Now it's for everyone, right? And so the crux to that component is if we are not participating in the experimental part, when it's ready for us to use, we then find out it's not relevant to us, or it hasn't been developed for us, or there are limitations in our use for it. And so that's really why we want inclusion in these clinical trials, because we want to know, is there something before we get it, if there are adjustments we can make before, we tell everyone that, this is for you. What can we learn about the populations that are getting this test to know, hey, in this demographic, you really should be adding this to your screening modality because it's providing additional coverage to where our current recommendations or our current screening guidelines are leaving us alone. In that Pathfinder clinical trial, and this isn't race or demographic associated, but the screening guidelines state that you should screen now 45 to about 79, 80 years old. We had 2 individuals, 80 years of old, diagnosed with colorectal cancer, right? And that's sad because the adherence to screening in this population was approximately 90%. But what it tells you is that at 80, those individuals were told, hey, you don't need to be screened for colorectal cancer anymore. And you know what? They ended up being diagnosed with colorectal cancer. I'm just saying that the guidelines, we have to recognize that guidelines or these recommendations are really for everybody, but are they for the everybody that includes you? So there's always some limitations with any technology.
Yeah, and I think what you also just mentioned, it kind of relates to the importance of maybe how this could be effective in diagnosing or detecting triple negative breast cancer in Black women. And so even more important for our community to participate in studies like the Pathfinder 2. But I know there's sometimes some aversion or skepticism when it comes to participating in clinical trials. And we've had sessions in the past where we've talked about
breast cancer.
How things don't work like, they did with the Tuskegee experiment or the Henrietta Lacks story, and that there are many, many more protections in place now for patients so that those atrocities don't happen anymore. And so, we try to do our part to educate the community about that, to encourage more participation so that we can go further upstream, so to speak, to try to close the gap in health disparities to make sure that when drugs get into market or other therapies get into market, we know with confidence that they are going to be effective in treating diseases that affects our community. And so on that note,
before you go on, I actually want to say, I want your audience to hear me clearly. Even though I'm advocating for you to be a part of this initiative, to be a part of our studies, I want you to be skeptical. I want you to remain skeptical. I don't think I or myself should be the one thing that persuades you. I want you to become informed. I want everyone to become informed, because here's the thing. Even the best intentions may sometimes be misdirected, but even on that note, not everything is perfect. So there may be a scenario with a clinical trial that's not meeting your expectations or your access to the test, or what happens after you get diagnosed, whether there's a limitation. So not only do I want you to be educated, I want you to be vocal. If there is an issue, if someone was to participate in this clinical trial or wanted this test, and they say, hey, there isn't a site close to me that I can be involved, or, I participated in the study, but they, essentially they didn't take into my patient history or my limitations, or et cetera, then we need to know that, because that's how we build a better study. That's how we make it more applicable. And so I want everyone to remain skeptical, especially when we know the history of medical studies upon various demographics and how that is played out, to where there's still a lot more to be done. So I don't think I think that it's important to remain skeptical and educated.
And be your own advocate, no matter what the
And
situation.
that's
Yeah.
probably the best way of summing it up.
Yeah. And so I want to talk about, what you're doing in the UK and also in Louisiana in terms of really opening up access to this technology to communities that probably otherwise would not have access to new and innovative technology. So can you talk about what you're doing with in the Ochsner system, which is the largest healthcare system in Louisiana, and what now is happening for patients, especially that are I think within the Medicaid system there?
Yeah. And so thanks for that question. I actually came from Louisiana just yesterday. There was a very big conference going on, and I was attending there, speaking to some physicians from around the world. And so much so we had, international people asking us, how do they get the test? But to that demographic, we understand that Louisiana is one of the states that has been detrimented by cancer. Their incidence rates, their mortality rates it's a population that desperately needs more, or maybe more of even what we should already be doing. But on that note, we've partnered with the largest healthcare system within that territory, Ochsner Health. And it's a long journey. Nothing happens overnight. The test is available commercially, but we've sought out specific health equity partners, and Ochsner is one of those institutions that saw the value in this test and decided to work with us to offer this test within the communities, right? The way healthcare system works, we usually have the hospital, and we have people who have access to that hospital within the immediate area. But where we really see the healthcare system often let us down is in the rural setting, right? When you don't live within X amount of miles towards a major healthcare center, you don't have access to screening, or maybe adherence is not really the easiest venture, considering that you can't get time off from work, et cetera. So Ochsner, along with GRAIL, are partnering to provide this test for over 7,500 individuals within the community population. And they will be a part of the study for the next 2 years, but there will be follow-up. But the goal is to let's not only provide access to the test, but what that will mean is it will mean cancers will get diagnosed early, and we will understand how does this impact the community. And so my experience with the state of Louisiana has basically been that people want the test, doctors want this test, and they're very interested. So I was very appreciative when Ochsner decided to move forward with this endeavor. Because we couldn't do it without community partners like this. But again, this goes back to patients need to be the advocates, because we're looking for more health equity partners. We're looking to work with more communities. And if you're telling your doctor or your institution that, hey, why don't you have this test? And they say, why don't we have this test? And they reach out to GRAIL, and then we figure out how can we partner together.
Great. I see that there are a couple of questions in the chat, so I want to take a pause for a minute in our conversation to entertain the questions here. So So someone wants to know the cost of this type of cancer screening.
Yeah, and this is, I'll be honest with you, it's not cheap. It's $949, but this is why we need to get insurance coverage for this test. And the cost of this test won't come down until we, believe it or not, until we have more people doing it. And so what we're seeing right now, the people who can afford it and have the means to do it are the ones doing this test. And that's just, that's the aspect of having new technology. It's most expensive when it comes out, but that bill that I talked about, that is an effort to get this cost in the hands of people who need it at a more affordable price. But unfortunately, there are multiple barriers towards us getting there.
Okay. And then the next question is, are you considering participants for the studies who are under 40 years old, who've had a family member with a cancer diagnosis? I guess somewhat having a family
history. Yeah, so believe it or not, that's a very good risk criteria. And some of our other like the Ochsner study will allow individuals to be under the age of 50 years old, but have high risk factors like hereditary cancer, family history of cancer. Because that Pathfinder study is slated to get reviewed by the FDA, its requirement or its eligibility criteria is 50 years and above. And so again, we have other studies that are conducting. Our reflection study is one of those studies, like the Ochsner. So the Ochsner partnership is actually a clinical study. So those patients will be enrolled in our reflection study as agreeing to be to participate as getting the test and participating in the study. So yes, there are other studies that will allow individuals under the age of 50 to get the test.
Okay, so someone wants to know, for the Ochsner study, is there an insurance requirement to participate? And what if insurance doesn't cover additional screening or procedures if something I guess within the test is detected?
Yeah, and so the individuals participating in the study have essentially been designated. They do have insurance coverage, whether that's Medicare, whether that's some other insurance. There are other insurance options within the area, but yes, there is a component to that. But even if they are under Medicare, then it will allow for them to be included in the study. And in being a part of the study, essentially there are pathways into getting the confirmation of diagnosis and et cetera. So that's a issue that we thought about before we ever enrolled the study, that this test is no good if it tells you something, but you can't do the follow-up procedures or diagnostic requirements associated with the test. And so everyone in the study is essentially has a pathway in the Ochsner study. Now the Pathfinder study, which actually also is ongoing at Ochsner, but various other sites, the diagnostic workup associated with your positive will be covered. And so the difference between those two is that the Ochsner study is actually a real world evidence study, but within the Pathfinder 2 clinical trial, like I said, available at multiple sites throughout California. If you were to have a positive result, the diagnostic workup associated with that will be covered under the study.
And then someone else wants to know, how often should you have the test? And should it be part of like your annual physical?
Yeah, so that's a great question. And so essentially where we have sort of GRAIL suggestions, but there are no guidelines, right? So currently there are no guidelines in terms of when the test should be done, meaning when you have a reference in how often a test should be done, that really shouldn't come from a company. It should come from an outside source, a regulatory agency, medical professional association, and so on. So I want to be clear in saying that we don't have an outside recommendation. However, we have a GRAIL suggestion, which is that there will be most benefit in the implementation of this test on an annual basis in high-risk individuals. So we're not talking everybody, we're talking individuals 50 and above. If you're under the age of 50, you should have other high-risk criteria like smoking, family history of cancer, hereditary cancer, high BMI, etc. Now, the reason GRAIL suggests that 1 year is not to make the most money from the test is actually when you look at the science, with a test that screens for over 50 different types of cancers, a prostate cancer can take 5 to 8 years to go from stage 1 to stage 2. It's just that slow growing. However, something like pancreatic cancer going from stage 1 to stage 2 in less than a year, right? And so if you were to do this, let's say not every year, every 2 years, if it happened to be a pancreatic cancer, you might have the difference between diagnosing in stage 1 to possibly stage 3 over those 2 years. And so that suggestion of an annual screening modality is really because if you're asymptomatic, and we don't want this test done in people who have symptoms. If you have symptoms, you should go to a doctor and they should they should do diagnostic workup for your symptoms. However, if you're an asymptomatic individual and this test is returning a positive, then it's designed to, on an annual basis, allow you an opportunity to detect it at the earliest time point.
Okay, great. And someone wants to know, you mentioned Sutter earlier, and someone wants to know how is this being addressed at sites like Sutter Health, and what are your plans to engage with health equity champions at Sutter?
Yeah, so Sutter Health is one of our partners for the study, so they're well aware of the test. They have physicians there who are ordering the test, so they're part of our clinical studies. There are physicians ordering it commercially, so we have and they've been a partner with us for a very, very long time.
So someone who's part of the Sutter system should just talk with their physician about it.
Yep.
Okay,
And
great.
there's actually, everything, and I always try to caveat everything, you shouldn't just believe what I say. Everything is available is on like clinicaltrials.gov. If you look for Pathfinder 2, and there they actually have all of the Sutter Health sites and also the contact information of individuals within those various sites on who you should be contacting. You can also go to Grail's website, grail.com, to where we also have Pathfinder. We have a link to the study and information there as well.
That sounds great. And so do you know if Kaiser Permanente is one, are they a partner of yours, or are you thinking about partnering with Kaiser?
To my knowledge, we don't have any of our studies or partnering with Kaiser across California or really on this test as yet. So, but I may be late to something, so that may change over, the next couple months. But this goes back to, if you go to Kaiser, if you advocate for this test, that's where healthcare systems really do make change, is if you're advocating for this test within your healthcare system, then they come to us, and then we can have a discussion about being a part of the system, partnering with us, because it isn't until somebody from their community tells them that they want the test, do they know, essentially, this is something that they should be a part of.
Yes. So I can't believe that time has flown by. I mean, it's almost 5 till 3, but I do want to give you an opportunity to say some parting words, or what message is it that you want to leave with the audience today about the importance of multi-cancer early detection technology, the Galleri test, and anything else that you think is important for them to know, so that they can be more informed, can ask the right questions, and like we talked about earlier, be their own advocate when it comes to cancer screenings.
Yeah, thank you so much for the opportunity. And first, before I continue, I want to thank you for the opportunity to be here today and address your audience. Being somebody who's been entrenched in the science of cancer for so long, where I sit now and being able to speak to you today is really an epiphany for me, because I've been a part of publishing great research and doing research for so long, but I really recognize that there's a problem in being a great researcher and leaving it at that. Right? Research without action is just not useful. If you can understand everything, publish everything, but you're not taking action on that actual research, then that in of itself is a problem. So we all need to take action. And when I say we, I mean me, I mean patients, doctors, legislators. It's a coordinated effort for us to really impact change across the healthcare continuum. And then the other part that I'd like to, this will be my parting or leaving my commentaries, the more we get it, the further along we get down this road, and we really look at the disparities between the demographics. I often think of that saying, that you have to be twice as smart to get half as far, right?
Right.
And
yes.
where every time I was literally at a conference in San Antonio just a few years ago, and they published that African-American women have worse outcomes than other demographics. And there really wasn't an explanation, it's just more, this is the data. And so more often than not, I'm often beat on the head that same saying can be applied in the cancer setting, to where the way I look at it is, when it comes to cancer, you have to be twice as lucky, and twice as vigilant to get the same outcome, right? And that's where it's not just what will the doctor do for me, what will the treatment do for me. You have to be just as part of this process. And it comes even into the screening space to where knowing, are you at high risk? Do I have, prevalence of cancer in my family? What type of cancer? Or even just, what are the what is going on in my life that just puts me into a group of high risk category to where I need to be more vigilant. So
Yeah, and sometimes it may be a function of where you live, and we know that there's definitely environmental factors that come into
yes,
play as part of the social determinants of health. So being aware of your health in many different facets is important. And so I hate to say it's time to go because I always enjoy talking to you, but I want to respect everybody's time. And I actually have a flight to catch, so I'll be heading up to Sacramento
oh,
in a few
good
hours.
travels.
Yeah, and so I want to say thank you so much for coming back and for sharing information and providing an update about what's happening with GRAIL and the Galleri test. You're welcome to come back anytime you have any news to share and want to impart some knowledge on our community. And
Well,
happy
I'm
holidays.
hoping after all of this and we have that Pathfinder study done and I come back and present the Pathfinder 2 results, I can tell you we had, I want 50% minority inclusion in that study if I can get it. So, hey, if we have the people, I'm going to advocate for, hey, let's do it.
Right. And so remind folks again where they can go to learn more. And if they want to enroll at a site somewhere, how can they do that again?
Yeah, so to be very clear, so GRAIL is the company, Galleri is the test. So you can go to galleri.com to learn about the test. You can go to grail.com to learn about the study and look for our Pathfinder 2 study or any of our clinical studies. There's a clinical study tab that you can click on, as well as you can go to clinicaltrials.gov, search clinicaltrials.gov Pathfinder 2, and it actually tells you the sites across the country. So even if you're not in California, if you're somewhere else across the country, we have sites across the entire continuum. I'm sure they can reach out to you directly and you will direct them towards towards us if there are any specific questions that we can answer. So
great. All right. Well, thank you, Jason. Have a great holiday.
and
Stay on just a few more minutes. I have just a couple of things left to share today. As part of playing our role in helping to educate our community about the importance of participating in clinical trials, we are part of the All of Us research program. That's a NIH, or National Institute of Health initiative. And the All of Us research program is about getting about 1 million people or more across the country into a health database and making sure that there is a diverse database so that researchers can use this database and learn about biology, lifestyle, and environmental factors that impact everyone's health. And so the purpose of this research program is to really know more about the risk factors for certain diseases, cancer included, figure out which treatments might work the best for people with different backgrounds that are different, from different race and ethnic groups, as well as the environment where people live, and to connect people with the right clinical studies to meet their needs. And then last, to learn about technologies that can help us take steps toward closing the gap in health disparities and creating a healthier community. So if you want to learn more about the All of Us program, you can go to allofus.nih.gov. And then just a reminder, you can connect with us in many ways. If you want to can't find what you're looking for with the Galleri test or GRAIL, you can always get in touch with us. Follow us on social. Most of it is at yourcbhn.com. You can be part of the campaign for Black Health Equity and also help us next year celebrate the 40th anniversary of CBHN. If you have any questions, you can email us at askcbhn@cbhn.info. And the last thing I want to say is happy holidays to everybody. Have a safe, healthy, fun, and fulfilled holiday season with your loved ones and your family. So thanks again for showing up today, and have a great holiday and Happy New Year.